Hello, web shadowers. Welcome back. Thank you all for joining us tonight. Today we have the pleasure of hosting Dr. Baig, who will be teaching us about interventional radiology. As always, please remember that the Google form will be posted in the chat in the description of this video when the session is over. With that being said, Dr. Baig, you may start whenever you're ready.
All right. Hey, everyone. How's it going? My name is Asad Baig. Thank you for the introduction. I really appreciate it. So this is just going to be like a basic intro to, what is IR, and, what can you expect from interventional radiology? What can you learn about it? So without further ado, let me just give me 1 second. All right. All right, let me know if you guys can see my screen. Are you guys able to see this this PowerPoint that I have loaded up? Can anybody tell me if you guys can see my screen? All right. Well, it just has your name. Oh, okay. All right. Let me see. Please grant browser access. Okay. Share. Sorry, everyone. I know we are having some technical difficulties. Let me just see. It's not allowing me to share my screen. I'm just going to do that real quick. Screen recording. Okay. Just try this one more time. All right, give me 1 second. I am going to leave and come back and see if that'll work. All right, just give me 2 seconds. All right, can you guys hear me? All right, so we're going to try this one more time. I am asking everyone if you can hear me and see the screen. It says that I should be sharing the screen. Can you see it?
Working now. Yeah, you're all good.
Oh, excellent. Okay, and you can hear me, right?
Yes, you're all set.
Oh my God, finally. All right, excellent. Okay. All right, so let's begin. We've got our radiology shadowing session. My name is Asad Baig. I am a sixth year, well, I guess fellow now. I'm at Emory down in Atlanta, and that is my handle at Asad Baig MD. All right, so what is radiology? This talk is really intended more so for pre-med, for med students, and kind of junior residents. If you're any of those, I think and I hope you'll benefit. So what is radiology? It's the medical discipline that uses medical imaging to diagnose and treat diseases within the bodies of animals, including humans. Basically, what it is using images to kind of get a diagnosis of what's going on with this patient. And obviously, Scrubs is one of the funniest shows ever. And clearly, JD is saying you have a hand inside of you. So that is one way that you can use radiology. It will work on Muppets as well. All right. So continuing with what is radiology, you're going to see a lot of different images, CTs, which is the same as CAT scans, MRIs, X-rays, ultrasound. That is kind of part of the diagnostic scope of radiology. And all of these images that you would see, whether it's X-rays here, you have a CT scan or a CAT scan here, you have an MRI here. These are all parts of radiology. Now, within radiology, we have the diagnostic side, which is when you look at the images and you interpret them. And then you have the interventional side. And intervention of anything means that you're actually doing a procedure or you're actually doing something to intervene. You're doing something that would basically kind of either help the patient in some way, where you're physically doing a procedure, or kind of getting a biopsy, and I'll talk about that a little bit later, right? So the actual definition of IR, or interventional radiology, is it is a medical subspecialty that performs various minimally invasive procedures using medical imaging guidance such as X-ray, fluoro, CT, MRI, or ultrasound. IR performs both diagnostic and therapeutic procedures through very small incisions or body orifices. Basically, that's a whole lot of words. That means that IR, what we do is we do minimally invasive procedures. It's basically like surgery, but there's no big cuts. We're using very small, kind of basically needle pricks to get to where we need to get to. And what we're using is fluoro. We're using ultrasound, right? Fluoro is a type of X-ray. Ultrasound is, when you have someone who's pregnant, that needs an ultrasound. We use that same kind of technology, but we use it for different things. We use it for treatments. We use it for biopsies, and we'll go over that in a little bit. Okay, so if you walk into an IR suite, that's what it's called, by the way. So, you have operating rooms where surgeons go and operate, right? You have cardiac cath labs. That's where cardiologists, they go and, they do their thing. We have IR suites, right? So when you walk into an IR suite, what you might see is you might see something like this. You're going to see kind of this machine, that is kind of like, it's a rectangular shaped, almost box like thing, which seems to be pointed down at the patient. That is actually a fluoroscopy machine, which is basically a type of X-ray. And the way that works is it's an X-ray beam shooting through the patient, and whatever's going on, we can see, on these big screens over here. Right. And these people over here that are kind of working would be the attending, the fellow, the resident, members of the IR team. And the way it works is you hit the X-ray button so you can see exactly what you're doing as you're doing it. So you can almost think about it like, it's almost like one of those, like a video game, or one of those hand-eye coordination tests, if you will. So there's a lot of hand-eye coordination involved with that, and it's kind of cool because all of these procedures are pretty much minimally invasive. So you're really not creating like these big cuts, these big scars, right? So what are we doing as an IR fellow, right? So what is your typical day like? So now keep in mind, this is the life of an IR fellow, right? Once you finish your fellowship, right, things become a little bit different. And for those who don't really know what a fellow is, I'm going to backtrack a little bit, right? So everybody knows to become a doctor, you have to basically go through the pre-med track in college, right? It's not fun, I know, right? You gotta do physics, you gotta do orgo, you gotta do all this stuff that may or may not be useful in the future. But anyway, you do all that. After your pre-med years, you go into medical school, right? After medical school, you do your residency. And that's when you are actually working as a doctor, as a physician, but you have to work under somebody. You're not allowed to practice on your own. That's during residency. Fellowship is when you take what you learned during residency and you basically focus on one aspect. So for me, I did a radiology residency. What I'm doing right now in my fellowship is like one specific part of radiology, which is interventional radiology. So anyway, I say all that to get to this. A typical day for an IR fellow, right? So I usually get to work around 6. It's pretty early, I know. Unless you're a surgeon, then you get in before us. So we usually get at work, check the sign out. Basically, we have a document where if there was any emergent cases, anything that happened overnight, basically, we would look at it and kind of, be aware of it and be prepared for it. At 7:15, that is when every member of the IR team gets together in one room and we discuss the day. So everything up to 7:15, right? From about 6, sometimes 6:30. Sometimes if it's really crazy, you come in a little bit early at 5:45. But that time up until 7:15 is for me and all of my co-fellows to basically figure out, all right, what are we doing today? What cases are we doing today? Right? Not only what cases are we doing today, have we seen the patient? Do we know why we're doing this procedure, right? What kind of procedure are we doing for the patient, right? What's the indication, right? We have to know, is this going to actually help the patient? Because we don't do procedures that, we shouldn't do procedures that don't help patients, right? So every time we do a procedure, we always say, okay, how is this going to help the patient? What is the indication for this? What's the reasoning behind it? So we think of all those things. We check labs, look at imaging. We do all of that before 7:15, because at 7:15, you better come correct, because that is rounding time. That's when everyone is there. That's when you got to present your patients. That's when you got to talk about your patients and say, hey, this is a blank, male or female. We're consulted for, kyphoplasty, and I'll go over what that is. This is a patient who had a fracture at L5 or whatever, something like that. So we do all that from 7:15 to 8. Then from about 8 to about 5 p.m., give or take, sometimes later, sometimes a little bit earlier. That's when we do all of our cases, all of our procedures. After we do procedures, we have to write a quick note. We have to do a dictation, basically kind of explaining exactly what it is that we did. And the way that the workflow goes in the hospital is that generally IR is a consult service. Meaning what? Meaning you go to the hospital, right? You have, let's say, some sort of kidney issue, right? So you're going to have the primary team, which is the internal medicine doctors. They're going to kind of be coordinating your care in the hospital. They're going to consult nephrology, because nephrology takes care of the kidneys. They're the kidney specialists, right? The kidney specialist may say, hey, you know what? This patient needs dialysis. This patient's kidneys are failing, and we got to do something to basically kind of allow them to function, because if your kidneys don't work, you can't really, it's not really compatible with life. So they may say, hey, put in an IR consult, because we would like for them to do what's called a permacath. It's a dialysis catheter that we would place that would allow patients to get dialyzed, to get the dialysis that's needed to live, right? We put that right by the neck in the chest area, okay? But the whole point is, once the nephrology team or the internal medicine team puts in an IR consult in the computer, it pops up on our list. And we see, oh, this is the patient's name. So then we have to go into the patient's chart. We have to talk to the team and say, hey, we saw you put in a consult. What is your guys' thought process? What's going on with the patient? Let's talk about it a little bit. Does it sound like a reasonable request? Does it sound like an unreasonable request? Does it make sense for the patient? So that's what we do when we look at consults, and obviously we go see the patient. So we do that up until about 5 p.m. Every place is different. Some places go till 5:30, 6. It's very rare for us to actually leave at 5, but usually the last case of the day is usually around that time. After that are call cases, basically any emergency cases. And I'll go into that in a little bit as to what are call cases. There is a question. Are IRs only located in major hospitals? No, absolutely not. There are lots of private practices that hire IRs. That this is a kind of a big misconception that if you're an interventional radiologist, you have to be at a big hospital. Actually, majority of the jobs that I'm seeing now, majority of the job opportunities that I'm getting are actually with private practice groups that will either kind of rotate through different hospitals, or sometimes they have their own kind of like private like IR suite, meaning not associated with a hospital. That's like actually the new rage, which is like called basically OBLs, office-based labs, which is basically kind of a freestanding, almost like a surgery center, but it's more so like an IR suite where you can kind of do procedures. So just getting back to the presentation. All right. So what are some IR cases, right? Because we always talk about, you hear IR, oh, IR is so cool, like this and that, right? Said nobody ever. No, I'm just kidding. IR is the best. But like what are these actual IR cases, right? Because everybody knows, right? Cardiology, right? They're going to do heart cases, right? Surgery, they're going to cut you open, right? Nephrology, they're dealing with just the kidney, right? The neurosurgeons, they're going to be doing brain and spine stuff, right? What the heck is an IR, right? So the beautiful thing about interventional radiology is you get to work on all parts of the body, right? And I'm going to go through a few cases, right? So there's something called the TIPS. It stands for transjugular intrahepatic portosystemic shunt. It's a whole mouthful, but yeah, basically we just call it TIPS for short. A TIPS, what does it do, right? For patients that have liver dysfunction, patients that have cirrhosis, right? One of the problems is that the liver is really important for blood flow, right? All of your, as this kind of graphic says here, there's the portal vein, which basically carries all your blood from like your intestines, right? And it goes to the liver. And then what your liver does is basically filters that blood and then sends it to the heart to go back into circulation, right? And that goes through the hepatic veins. The hepatic veins carry blood from the liver back to the heart. So in patients who have liver dysfunction, they can't actually do this. So their liver isn't like working properly. So what we have to do is we have to basically create a way for the blood to flow. So what we do is we put a shunt, or basically a little piece of plastic, in between the portal vein and the hepatic vein. And what it does is it allows the blood to flow in the way that it should. And this is a case that can help a lot of patients. And what does it look like, when we see it, right? When we're doing the IR procedure. So this is what it looks like, right? You have the cartoon image, kind of on the left, and on the right, you have what we call an angiogram, right? When we put the patients on our table, right? When we start injecting contrast, which is a dye, what do we see, right? So this is that TIPS that we were talking about, right? This goes into the heart over here, right? And then you see the portal vein, right? It's going in here, right? And the TIPS is basically connecting the portal, venous blood, and it's dumping it back into the heart, which is basically the function of the liver. But when your liver can't do it, you need to be able to do it. So that's one way that we do it, right? And the way that we do it is we go down the jugular vein, go through the heart, go into the liver through the hepatic veins that we see. We go through the liver tissue and we connect it to the portal vein. And the way that we do that is we use balloons. Literally, we'll take balloons and pump them up to basically create a channel. And then after that, we put this stent, and now you're going to see that the blood is going to flow from the portal vein into the hepatic vein and up into the heart. All right. Can I make it full screen if possible? Yeah, absolutely. If I knew how to do that on on Google Slides. Let me see, 1 second. View. Full screen. All right. Did that make it full screen or no? All right, let me know if it's full screen. If not, listen, I tried. All right. All right, here's another case, okay? We've got basically for women that have very heavy period bulk symptoms, right? It may be due to fibroids, right? Fibroids are basically what? They're basically kind of tumors that basically kind of suck up blood. And what they do is try clicking present. Okay. Let me see. All right. Sorry, guys. This is what we got. All right. I'm almost done. Don't worry. It's not gonna go too late. Yeah. So basically, the way that this works is women who have this issue. What's going on is they're getting too much blood flow to these fibroids, which are basically kind of these tumors that will kind of be like act like parasites, right? They just keep sucking blood, and what they do is they get bigger and bigger and bigger, and they cause like really really painful periods, right? So what do? Right? We go in through the arteries, right? We'll go up and over. We'll go right to the vessel that's supplying the fibroids. And what we'll do is we'll cut off the blood supply. And what that does is that basically kind of shrinks the fibroid over time. And you can see actually on this MRI. Now I know you guys are not radiologists. That's okay. I don't expect you to fully know what's going on. But what we're doing is we're looking at a person, we're looking at a woman in the sagittal view. What it means is we're looking at a side view, right? So this is the spine right here, okay? This is the uterus right here. Now you can see pre-uterine fibroid embolization. You see this really big mass that this arrow is pointing to. And 6 months later, it's completely gone, right? And the way that we do that is called embolization, where we just basically cut off the blood supply, all right? Um, and let me see. And this is what we would see, right? So you can see like on the left, there's like this huge tangle of vessels. And it's just, it's all crazy looking. It's like your hair when you wake up in the morning, right? Um, and then after you do the embolization, you're cutting off the blood supply, and you see that all those like crazy tangled vessels, they're all gone. And that's the goal. The goal is to basically kind of get rid of all of those vessels that will basically be supplying these fibroids. Um, Before I go on to the next case, there is a question for the patient who needs dialysis. When you put the device in the body, is that the device that feels like a vibration or a buzzing feeling under the skin? I had a family member who had a procedure done. Sometimes it can when you get dialysis. So you may be talking about like a fistula, like right under the skin. Basically, what you're doing is you're connecting an artery to a vein, and that is where they would get dialyzed from. Yes, yes, exactly. We do a procedure like that, but the way that surgery does it is basically you have to cut the arm, and then you have to basically connect the vein and the artery together. The way that we have started to do it, there's something called endovascular fistula creation, where basically you don't have to make that huge cut. It works only for specific patients, but basically the way it works is you go in through the vein, in through the artery. One way of doing it is you use magnets to basically kind of join them together. And what ends up happening is you connect the artery and the vein, and that's one way of creating a fistula. So yeah, that is something that IRs would definitely do, and I see that becoming like a bigger thing in the future as well. Now going on to the next slide, right? Okay, let's say, and I'm just trying to show you kind of the breadth of IR and kind of how vast it is, right? So what happens if grandma or grandpa is walking and God forbid they have a fall and they get a fracture in their back, right? What are the options? Number one, you can have surgery, right? If ortho and neurosurgery say, hey, like, this is not something that needs operating on, but you have a fracture, right? And they're going to say, hey, just put on a brace. Let's have some pain control and give it, maybe 4 to 6 weeks, maybe 6 to 8 weeks, and, it'll be healed. I mean, that's one way of doing it. That will work, but I don't know if you really want to keep grandma, grandpa, kind of bedbound for 6 to 8 weeks, especially elderly folks, they have to get around, they have to get moving and everything. So what we do is something called a kyphoplasty. And what it is this, right? When you have this kind of crunching of the vertebral body, and you can see it's kind of flattened out like a pancake. You see the one on top is normal, the one on the bottom is normal, right? Where it says needle, that that vertebral body, that one is pretty much almost like a pancake, you can see. So what do? We go in with a balloon, right? We go in the through the bony parts of the spine. We go into the vertebral body, which is right here, kind of this Lego block here. We blow it up with the balloon to get some height back. And what we'll do is we'll put cement in there. And what that does is basically kind of gives it stability, and it also helps with the pain as well. And so this is what we would see, right, on an MRI. And you can see that where it says fractured vertebra, that is like definitely flatter than, for example, the one below it or the one above it, right? And when you go to the fluoro imaging, right, you see that we can go in right with the needles, right, go right into that vertebral body. And what we'll do is we'll put the balloon up and we'll inject some cement. And basically what that does is that gives it stability and it helps with the pain. So those are just some of the cases that you can have with IR. And there's so many other cases that we can do. Venous recanalization, basically, if you have a vein that's blocked off, whether it's from a blood clot or whether it's over time, we can basically open up that vein. We can open up the arteries in your legs, in your arms. We can put stents in to keep them open. If somebody has a trauma, if they had, if they got into an accident, car accident, or God forbid they get shot or stabbed and they're bleeding, and it's in a place where surgery can't get to, where if it's like in the pelvis or something, they may call us and say, hey, there's a patient who's bleeding and is really unstable, like we need your help. So what we would do, similar to the fibroids, is we would go through the arteries right to the point where it's bleeding and basically kind of stop the bleeding. HCC, hepatocellular carcinoma, that's liver cancer. Liver cancer treatments we treat them using chemo, by going right up to the tumor, right? Treat them with chemo, treat them with embolization, treat them with something called Y90, which is basically kind of it's a radioactive embolization type. Okay, we can place ports for chemotherapy. We do permacats for dialysis, drains. We do nerve ablations. People who have arthritis in their knees, for example, right? We've been doing, especially down here at Emory, we've been doing so many nerve ablations that actually really help people, and it kind of delays them having surgery. It gives them a few more years, and some people, they just keep getting these, and it really helps them in terms of pain. All right. If you have a pulmonary embolism, blood clot in your lungs, these are things that we all do. Let's see. Is it a special kind of cement? Going back to the kyphoplasty thing. Yeah, it is a specific type of cement that is basically, safe for the body. And what it does, it also kind of heats up a little bit. That's part of the way that it kind of helps with the pain. That's also part of the way that it helps with the stability. And does the cement deteriorate over time and need to be replaced every so often? So actually, that's funny that you asked that, because we were just having a discussion probably about a week ago. So the way that billing works in America is actually for kyphoplasties, you can only bill a patient for once in their life for one specific level. So if you do a kyphoplasty at one level, that's it. The expectation is that it's one and done, meaning once that cement is in, the patient should not need anything else in the future, and furthermore, in addition, if you have to go back and basically kind of redo it, your hospital or your group or your private group that you're working for, you may not get paid for it, because the way that the system works in America, especially for kyphoplasties, is it's supposed to be a one and done type of procedure, meaning once you do it at one vertebral body, it's supposed to provide enough stability, excuse me, and enough pain control that the patient should not need another kyphoplasty at that same level. What is a nerve ablation? Great question. So a nerve ablation is exactly what it sounds like. You're basically destroying the nerve. And I know that sounds scary and that sounds crazy a little bit, but I promise you it's not. We've done quite a few of these. We actually at Emory, we just published a study actually kind of looking at these genicular nerve ablations for patients with arthritis of the knee. So the way it works is you use radio frequency waves, basically kind of a type of sound wave to basically kind of destroy these nerves. And the way that it works is you have to check and make sure that you're not touching any of the nerves involved with movement, because there's two different types of nerves. There's your motor nerves, which actually help you move, and then there's your sensory nerves, which make you feel things, which, when you feel pain, those are the nerves that are firing. So what we take out is actually the sensory nerves, so that, when you have arthritis, some of that pain that people have is like unbearable. And it's amazing. You see results like a couple of the cases that I've done, it's like they'll come in with like patients will come in with like 7 or 8 out of 10 pain. And literally right after the procedure in the recovery room, like I go with them and I take them on a little walk and I ask like, hey, what's your pain level now? And almost always it's been like, I don't feel any pain, or like maybe 1 out of 10 or maybe 2 out of 10. Like it's a significant, like drastic, like difference. So that's kind of exciting, and that's something that we do, excuse me, and that's on the horizon. Um, any questions? I welcome any questions. My information is here. The best way to contact me would probably be through Instagram, or if you want to email us, asadbaigmd@gmail.com. I'm going to stop sharing my screen, and let me see if I can get the start my video up. Oh, okay. Yeah. Yeah. So let me know if you guys have any questions about IR in general, about becoming a doctor. I don't mind, answering questions for another, kind of, 5, 10, 15 minutes, whatever. Is that a good approach for rheumatoid arthritis as well? Rheumatoid arthritis is a little bit different. The pathophysiology is a little bit different than traditional like osteoarthritis. Excuse me. So the treatments are a little bit different. We usually don't do this for rheumatoid arthritis. I don't know if in the future that's something that it can be looked into, but for now, that's not really something that we would do for rheumatoid arthritis, because rheumatoid is more like an inflammatory condition. More often than not, if you treat the underlying rheumatoid issues, the treatment is just a little bit different. So that's that. What else? What other questions you guys have? Feel free to ask, any questions that you have about, medicine in general. What made you want to go into it? That is a great question. So I kind of have an interesting story where originally I had thought I wanted to do surgery, and basically I did it for a year, and I said to myself, man, I really don't see myself, doing this for like, for my whole life. So I was like, all right, what else can I do? Right? What else would I like to do? I like orthopedics, right? I like the bones. I like doing that kind of stuff. But then I also learned about IR, and I was like, man, this kind of stuff is kind of cool, because like it's basically what the future. This was me like 5 years ago thinking. I was like, this is kind of like what the future is going to be, because everything is minimally invasive, right? So you're not making big cuts. The patients love you because you're not, you're not sending them home with a big scar, right? Everything you're doing is basically within the body, and you're looking at it with ultrasound X-ray. I was like, this kind of stuff sounds really cool, And I said, you know what? I think I'm going to go for this. So I applied to radiology with the thought that, okay, I'm going to go into IR. Because at that time, there was no IR residency. Now they've developed a new IR residency, but when I applied, there was only regular radiology. So I did my regular radiology, and then I went into IR, and I am, it's hard work for now, you know what I mean? Like as a fellow, it's definitely work. Like I'm not gonna lie to you. It's every day is pretty much a busy day, but I'm very glad with my decision. I'm very grateful that, somehow I ended up here, because I got to be honest, I didn't even do a single radiology rotation in med school. I had initially thought, I was like, man, radiology, that's boring as hell. Like, I don't want to do radiology, you know? But when I learned about radiology, when I learned about IR and actually did it, I was like, all right, this is not bad. That's another thing I would pass along to you guys is that, make sure you really know whether, it's about going into medicine, or it's about going into a specific field of medicine. Make sure you really know the field, because there are these kind of preconceived notions that people have, myself included. I had my own notions about radiology before I actually went into it. You know what I mean? So all right. So I kind of answered what made you do IR, what made you do radiology. And radiology is like, it's a really good field because you have a lot of variability, right? In the sense that you can go interventional, right? If you don't really like doing so many procedures, you can go into something where you're looking at more images. You know what I mean? Um, you can't go into like musculoskeletal imaging. Like, if you're into sports, right? All these like athletes, right? When they have ankle sprains or when they have, ACL tears, MCL tears, like who do you think is diagnosing that? It's a radiologist, right? It's a radiologist looking at the MRI, looking at the X-ray, the CT scan, and saying, oh, it's an MCL tear, or it's a high ankle sprain, right? A couple people on my fantasy football team, right, have injuries. So it's like, who's diagnosing that? It's a radiologist. So that's another reason why I chose radiology, because it's pretty much involved in like every part of medicine. How many years is your fellowship program? So the way that the IR fellowship program works is it's either 1 year or 2 years, right? My fellowship is 1 year because my last year of residency, I did a program called ESIR, which is early specialization in IR, where basically you do like a mini fellowship in your final year. You do about 7 to 8 months of IR, and they count that as equivalent to 1 year fellowship. If you don't do one of those, then it's a 2 year fellowship. Okay. How do you balance your time while in fellowship? Medical field can be so time demanding. How do you make time for self care and hanging out with family and potential significant others? So great question. It's hard. It's really really hard. And it all comes down to what you want out of life. You know what I mean? Um, if medicine is your true calling and that's what you want to do, no matter what field you go into, there's definitely a lot of sacrifices, right? Um, I have missed certain events of certain weddings. Listen, I am I am from a culture where weddings are like, it's not a 1 day thing, okay? It's a multiple day thing. So I've missed certain events of like some of my really close friends because I've had a med school exam or whatever, you know what I mean? So there's definitely a lot of sacrifice to be made. However, the thing that you gotta realize is that no matter what you do, if it's worth doing, it's gonna take up a lot of your time, right? It's gonna take up a lot of time, and it's up to you and me to figure out, all right, how am I gonna balance this, right? So the way that I do it is pretty much when I'm home, I try to get all my work done at work, right? That's what I really try to do. When I'm at home, I try to hang out with family, friends. Fellowship year is kind of hard because it's really kind of like very grueling, very demanding. During residency, though, I was very lucky that I had, I was pretty close to home. I was in New York. That's where I'm from originally. So I was able to hang out with a lot of my friends like on the weekends and stuff, like when I wasn't working. So it's definitely doable. It's just a matter of kind of time management. Why did you choose Emory? To be very honest, I interviewed at a time. I know this is kind of crazy to think, but I interviewed pre-COVID. So I actually interviewed when COVID was almost a thing, but not a thing. Um, so half of my interviews were virtual and half were actually in person. So Emory was actually one of my first interviews. I remember it was February of 2019. And so I went down to Emory and absolutely just fell in love with it. Really nice facilities. But what really sold me was the program director. The program director, incredible guy, Dr. Majolani, super accomplished, but super down to earth. Like, really nice guy, like joking around and everything. And for somebody so accomplished, somebody in academia, somebody who could basically relate on a human level, he really sold me. And this is something that I would encourage all of you, wherever you end up, like make sure you like the place that you're at, right? Because more often than not, you're gonna get great training. Like Emory, like is incredible with training. But like, a lot of the places that I interviewed at, they had very good track records, and they had a wide variety of cases, which of course Emory has as well. So it wasn't so much like I knew that the training was going to be very good, but for me, it was like, all right, do I see myself fitting in here? And I was like, absolutely. Like, I really like the culture that they're building here. I really like the people here. Um, so that's kind of what sold me on Emory. And it also doesn't hurt that it's like super busy, and like, we do like all kinds of crazy cases, which, I hadn't seen or done before, which I love because I mean, that's what you want. You want to be busy during your fellowship and senior residency years because you want to see everything before you have to go out on your own. Um, when you are a resident, can you change your residency to another if you change your mind along the way? Absolutely. That is what that is what happened to me. I was going to be a surgeon, and then I switched to IR. So you can absolutely change during residency. Best advice you would give to a sophomore pre-med to have a competitive application. All right, so here's what I would say. Right, first of all, it's great that you're thinking about it. Second of all, try to enjoy your time as well. Try to enjoy your time in college. I know it's really stressful. It's real hard. I know there's COVID, so it's not exactly the same. But if you have the opportunity, try to enjoy that time. But in terms of getting a competitive application, your grades are going to get you in the door, right? So things that you have to kind of do well in, right? You got to do well in your sciences, right? You got to do well on your MCAT. Now, all that being said, everything is an average, right? So if your grades aren't as good as the average, or if your MCAT isn't as good as the average, does that mean you should quit? Hell no, right? You should definitely still go for it, right? But you have to know that, hey, it might be a little bit harder. I might have to take a different route. I'll give you an example. My sister, amazing, right? She applied to medical school a few times and got rejected a couple of times. Initially her grades were a little bit lower than they should have been. So she went back to school. She did a master's. She worked as a scribe. So she hustled, she grinded, and third time's a charm. She got in. You know what I mean? So it doesn't mean that you're not going to get in, but you might have to work a little bit harder. But what I would say is make sure you do well in the classes that you have to do well in, right? Sciences, and do things that you actually like. You know what I mean? Like when you're volunteering for stuff, like do things that actually might be fun. Don't do things because it's going to look good on your resume. Honestly, to be 100% honest, anything could look good on your resume. Literally anything, right? All you got to do is kind of just write it in the right way, and it'll look good on your resume. So do something that you like. Do something that you enjoy. All right. Georgia-based student. All right, cool. And Emory is on my radar. Can you speak to your experience there? Yeah, absolutely. So Emory is awesome in the sense that you will see like all kinds of stuff. Like people drive from like hours away to come to Emory. And the reason is like a lot of the people that are doing stuff at Emory are some of the best in their field at it. So like you're learning from these like legends and giants who have like written papers and stuff, and they basically kind of like one of the attendings, he worked on creating a device that like lots of people use like for transjugular liver biopsies. You know what I mean? Like when you're at a place when you have like people like that just that are just so accomplished in their field that you're learning from them, and you see the wide caseload that it is, and you see the wide variety of patients. Like for me, it was a no-brainer. So I think that if you are thinking about Emory, it's a really good place to do your training. Do you do any procedures related to the brain in IR? Yeah, there's a whole field of IR, basically neuro IR, where basically if you have an aneurysm, you'll coil it, right? Neuro, some of the kyphoplasties that we were talking about. There are things called lumbar punctures that you would do, so there's a whole bunch of stuff. The other thing that you would do is like carotid artery angiograms, right? Looking at the carotid artery, making sure that there's not too much plaque there. That's something that neuro IR folks do as well. So that's a whole nother subspecialty. That's like IR, like further specialized IR, if you want to. But yeah. What advice would you give to someone prepping to take the MCAT? So first thing I would say is your score does not define you. So don't put too much pressure on yourself, right? Obviously try your best. You know, put in all the effort. If it works out, great. If it doesn't work out, it's not the end of the world, right? I think these days we're kind of taught to just kind of measure our worth based on a score, which is no good, right? So what I would say is that's the first thing, right? And the mindset should be, I'm going to try my best. I'm going to do my best. And, you know, whatever happens, happens, but I'm going to make sure to put in all my effort. And if it doesn't work out, that's okay. If it works out, great. Now, I would say make sure that you have a study schedule, right? Write down, and this would basically kind of apply to all levels. I would say come up with a schedule, write it down, write down what you want to accomplish that day and that week. You could even do it for the month. But once you start writing down your goals and exactly what it is that you want to accomplish, I think you'll find that you're going to accomplish a lot more, right? The other biggest thing that is probably going to help you a lot is practice questions, right? Studying the material is very important as well, but practice questions, practice questions, practice questions. Those are the things that these days, all tests, right? All tests, you just have to beat the test, right? So the way to beat it is basically get an experience in questions that are similar to it. So do the question banks as much as you can. Whatever question banks you can get your hands on, do them. Okay, and make sure that you're understanding the questions and the explanations as well, right? Because you have to also train yourself in how to think. So that's why I would say practice questions, practice questions, practice questions. Okay. First year medical student to be a great future applicant for IR. All right, here we go. Yeah, so basically what you want to do is if you have some sort of IR interest group or something like that at your medical school, right? Be a part of that, right? Get involved with IR early, right? If your medical school is affiliated with a hospital, right? Go reach out to the IR department. If there's no IR department, there will definitely be a radiology department. You can go to the radiology department and just say, hey, who are the IR attendings? And just go over there, just introduce yourself, be like, hey, my name is so and so. I'm a first year medical student, but I'm interested in IR. I'd love to come shadow you at some point. See if they're open to it. You know, most IRs will be like, sure, you know, welcome. If for whatever reason they say no, either try somebody else, or the other thing you could do is say, hey, are you working on any research? Like, I would love to get involved with some sort of research, because that's another way that you can just get involved, get your face out there, and show people, hey, like, I'm super interested in IR, because people want people who want to be around. You know, I want to work with somebody who wants to work with me. I want to work with somebody who wants to be in this field. You know what I mean? Like, I don't want to work with somebody who, like, this was kind of like a fallback option for them. Like, no, if you don't want to be here, that's totally cool. Like, I'm not going to hold it against you, but I would rather work with somebody who actually wants to be here. So show your interest. So that's what I would say for, you know, first year medical student. Again, it is very early. But it's good that you're thinking about this, because IR is pretty competitive. So reach out. Don't be afraid. Don't be shy. If you ask 10 people, you know, maybe 3 or 4 may say yes. Maybe 2 or 3 may say yes. But it's a numbers game, right? If the first 3 or 4 people say no, like, don't be discouraged. Just ask somebody else. There's always going to be somebody who's willing to do it. Don't be shy. All right. Advice for a junior applying to medical school next cycle. Okay. Just be realistic about your application, right? One of the most difficult things in life is being honest with yourself, right? Whether in a good way or a bad way, right? So you got to be honest with yourself. What is your application looking like? Are you a competitive applicant, right? Are you slightly below what's considered a competitive applicant? And that should kind of guide where you're going to be applying to medical school. Now, I'm not saying if you have low scores or whatever, don't apply to some reach medical schools. No, you can absolutely apply to them, but just go in with the mindset that say, hey, like, I understand where I am. I'm not giving up or anything, but I have to also be understanding of the landscape, right? Like, if I have below average scores and below average MCAT, like, I have to do something else, right? I have to hustle, right? I have to show these medical schools that I'm interested in. So that's what I would say. Know your application, right? Know your application, and regardless whether you're a good applicant or a quote unquote below average applicant, right? Reach out to programs, reach out to medical schools, right? Show your interest, right? Again, it works the same way, you know, as residency and pretty much everything else in the world works, in terms of, you know, if you make a good impression on somebody and show that you're really interested, you never know how long that's going to carry you, you know? So that's what I would say for the junior plan of medical school. Did I take my MCAT during college? Yeah. Yeah. I took it between junior and senior year. My sister took it after senior year. So, one of my best friends took it after senior year. One of my really good friends took it junior year. So it's like, it's very variable. But after you take the MCAT, usually you have to wait a little bit of time before the score comes in and you can actually apply to medical school. What do you feel the most challenging aspects in IR? Yeah, one of the most difficult things is kind of determining what is best for the patient, because in IR we always think that, hey, we can do anything, because once we get access to the body, we just use the arteries and the veins, we get to where we need to get to, and we can embolize, we can do whatever it is that we got to do. But the most difficult part becomes saying, okay, let's critically think about this. Can we do this procedure? Of course we can do this procedure. Is this what's best for the patient? In certain cases, the answer is no. And learning to say no is probably the most difficult thing. And learning how to say no is probably the most difficult thing as well. Because the thing is, right, when you get consulted for something, right, you can't just say like, no, we're not going to do it. Because the reason that you got consulted for something in the first place is because another doctor thought that there's something that you can offer that may help this patient. And ultimately, at the end of the day, what's the goal? The goal is always to help people at the end of the day, right? The goal is to help these patients. So somebody, a physician, another physician is thinking that, hey, there's something that you can offer that would be helpful to this patient. And if you just go and say no, like that, first of all, it's kind of rude. Second of all, it's like, all right, you're just completely disregarding this guy's, or girl's or whatever, train of thought, right? So before, you say no, it's important to critically think about it and say, all right, we could offer this, but we think that in this case, it may be better for a GI intervention, maybe better for a surgical intervention, especially something like, for example, a G tube, which I didn't really talk about, like a feeding tube to the stomach. We place those all the time, right? But in certain cases, it's better for GI to do it, depending on the anatomy. In certain cases, it's better for surgery to do it, especially if someone has had prior surgery and it's difficult to get through. So understanding those cases is probably the most difficult part of IR, and because we're all over the body, it's like we don't just focus on like one thing. It's more like, all right, we have to kind of know a little bit of, not a little bit, but we have to know in depth pretty much everything. How much research do you get to do in IR? A lot of it is depending on you. If you're really into research, definitely go to an academic place. Like if you're at Emory, like they really encourage research a lot, like heavy. But if you don't want to do research, that's totally fine as well. But yeah, just know that wherever you go, certain places are heavier on research and certain places are not. Does email in school I'm interested in enough to show interest, or how to communicate that? Yeah, email them, call them. Don't obviously break any rules, but you want to show, hey, like I'm interested, right? So if you email them and you don't get a response, email them again a week or 2 weeks later, right? Like, what's the harm? It's not like you got a response in the first place, right? Just shoot them another email, right? Obviously, when you do it, you want to be tactful, you want to be respectful, right? I took a writing course from like there was an author that came to I went to NYU, and I took a writing course, and one of the things he said was basically when you're reaching out to somebody, the most important thing is to be persistently respectful, right? So be respectful, but be persistent, right? So if you don't get a response, email again in a week or two, right? And what you should say basically is, hey, like, I'm totally interested. Do you have tours, or is there a way that I could learn more? Or ask like a specific question that would elicit a response. You know what I mean? Like just saying that I'm interested in, it's like, okay, cool. This guy's interested. All right, this girl is interested. This person is interested, whatever, like get a million of those a day. But you also want to make sure that you do your research on the school. Like if there's something specific about that school, mention that in the email. Like be like, hey, I heard about your anatomy lab or something that it's really state of the art. Like I would love to take a tour of it sometime. Like I'm very interested in this or something. Like say something specific about the school that would catch someone's attention, because that's what you want to do. Because believe me, I was a chief resident last year, and we get emails all the time. We get applications all the time, and like it's really hard to sift through. So it's like when something sticks out to you, or somebody really shows something that would kind of stick in your mind, like you remember those. So be memorable to to people in a positive way, not in a negative way, of course. All right. So emailing is good. If you find a phone number, call them and just say, hey, my name is so and so. I've heard such great things about your program. I would love to come take a tour, or I'd love to learn more about your program. Like, where can I learn more, or can I speak to a medical student at your institution? Something like that, and basically it shows like, oh, this person is serious. All right. What do you think IR or radiology in general will look like in the future? Like any big advancements? Yeah, I mean, like every single year, like especially in the world of like oncology, interventional oncology, which we do a lot of. It's like every year there's like new advancements, this kind of treatment, that kind of treatment, for this type of cancer, that type of cancer, there's constant like innovation in terms of like what procedures we do, right? Now the new procedure is like basically creating a fistula for dialysis without needing to make an incision, which is wild. you know um, that's real cool, right? So that kind of innovation is always coming about. The other thing with radiology in general, the hot topic is AI, right? Artificial intelligence, right? So AI is actually currently being used, right? But it's not being used to just kind of read all the images, right? The way it's being used is to kind of triage, all right, what is the most crucial imaging right now? Like, what is something that we think could kill a patient? Let me bring that to the top of the list. So the radiologist looking at it knows that, all right, this is the most important thing. Let me open this up right now. So that's how AI is being used right now. And it's going to be used in different ways, like in the future as well. So there's always going to be constant advancement. There's always going to be new procedures, new equipment, new materials being used, but yeah, so there's always going to be advancements. That's the thing. When you have such giants in the field, kind of like moving the field forward, like that's what's going to happen. So, all right, it looks like that's the last one. Thank you guys for having me. I appreciate it. I hope you guys learned a little something. If you did, feel free to, shoot me a message on Instagram. Usually, I'm pretty good about responding there. If you have like a longer question or something, feel free to email me. That's not a problem. My email is also on my Instagram. It's just my name, asadbaigmd@gmail.com. And that's it. Hope you guys enjoyed it.
Thank you so much for such a wonderful presentation and taking the time to answer everyone's question. I will have his socials and everything else linked in the description box of the video. And today's link of the Google form is sent in the chat box. And as always, you have 30 minutes to complete it. It will also be in the description of the video as well. And we all hope to see you in our next sessions. Thank you so much, everyone.